Thank you, Aaron, Michael, and Kelly, and welcome everybody. We're excited to have you here today. Before I introduce our speaker, I just wanted to give a quick overview of the Anxiety Institute and the services that we offer. So at the Anxiety Institute, we specialize in treating anxiety disorders and OCD. We work primarily with adolescents and young adults, ages 13 to 25. We have two locations, one in Madison, New Jersey, and the other in Greenwich, Connecticut. We have an intensive day program that clients attend 4 hours a day, 5 days a week. And what kind of separates us from a lot of other programs is the amount of individual support clients are getting. So we're doing 10 hours of individual therapy on a weekly basis, in addition to group and wellness. We also offer individual outpatient services, so clients can come to us once or twice a week for therapy, exposure, whatever they kind of need. And if anybody has any additional questions, I will also put my information in the chat. And without further ado, I'm going to go ahead and introduce our speaker, Dr. Omar Canosa. So Dr. Canosa joined the Anxiety Institute with 15 years of experience as a child, adolescent, and adult psychiatrist. After earning his doctorate in medicine in 1999, Dr. Canosa completed his general psychiatry training at Temple University's School of Medicine and fellowship in child and adolescent psychiatry at Drexel University's College of Medicine in Philadelphia. From 2008 to 2014, Dr. Canosa worked for the Atlantic Health's Overlook Medical Center in Summit, New Jersey, excuse me, where he spearheaded the evolution of an integrative and evidence-based pediatric eating disorder program. Dr. Canosa has been in private practice since, providing comprehensive mental health treatment uniquely tailored to each patient's individual needs. As an integrative psychiatrist, Dr. Canosa incorporates a range of healing traditions into his clinical interventions, intensively trained in dialectical behavior therapy, medical acupuncture, and I'm probably saying that wrong, so I apologize. Dr. Canosa is dedicated to both addressing symptoms and problems, as well as to maximizing each client's well-being in all areas of life. As medical director of Anxiety Institute, Madison, Dr. Canosa works closely with the professional team to provide medical perspective and integrative guidance to the psychological approaches of programming and treatment. He will consult individually with clients and families to discuss the potential benefits of medical treatment options when applicable. And without further ado, take it away, Dr. Canosa.
All right, thank you so much, Kirsten. How am I doing on audio and video? I guess you guys, okay, good. Today I'll be presenting on the pharmacotherapy of severe, complex, and treatment-resistant anxiety disorders. Based on the CE information that I saw for the presentation, I'm assuming the majority of the participants are not prescribers, and that's fine. I think that this presentation is mostly geared towards providers that aren't prescribers, but are still having to be conversant in the pharmacotherapy that their clients are undertaking. Because as we'll see, the pharmacotherapy really needs to subserve the overall treatment goals. A little bit about me. I'm a child, adolescent, and adult psychiatrist and intensively trained in DBT, also formally trained in cognitive behavior therapy for panic disorder and for eating disorders. So I wear both hats in my clinical practice, the psychotherapist and the psychopharmacologist. So let's start off with an overview of anxiety disorders and the current state of treatment. Anxiety disorders are so common that it boggles the mind. I mean, the numbers are huge. 1 in 3 people lifetime risk, but another way of framing that is that at this moment, there's about 270 million people in the world with a diagnosable anxiety disorder. And the truth is they're incredibly impairing, more so than most people realize. I mean, the impairment isn't that obvious, let's mobilize the troops, this person needs help sort of impairment. It tends to be more covert, with people and those around them kind of assuming this is the way they are, the way I am, and this is the way I'm always going to be, which is less than ideal, obviously. And they're extremely costly, and these numbers speak for themselves. And they're truly understudied. As surprising as that may seem, the psychotic illnesses, mood disorders have gotten a lot more rigorous academic study than anxiety disorders, especially in terms of how anxiety disorder outcomes could be improved with regards to level of functioning and quality of life. So as a broad overview, anxiety as an emotion is, a driver of that anticipation of future danger and the promotion of vigilance to make sure that that future danger is in some way dealt with, usually by avoiding it. Okay, good so far.
We're in business, yeah.
Now the next question is, can I see my presenter notes? Because now I can't see them either. Okay. So folks, I may be winging this a little bit now since I can't see my presenter notes. Hopefully, I won't do too bad a job of it. Just 1 second to see if I can bring them up. All right. So as I mentioned, anxiety as an emotion is a driver of that anticipation of future danger, to promote vigilance, so to promote attentional regulation and the service of preparing for future danger, and that urge to prepare for future danger results in cautious or avoidant behavior. Very adaptive when it's moderate and in context, but when it becomes an anxiety disorder, it's a group of clinical conditions in which the excessive experience of anxiety, in terms of how much is there, how often it's there, how long it lasts, winds up driving maladaptive behavior. Structurally, the way they're composed, anxiety disorders are actually fairly simple. They're composed of elevated levels of anxiety, cognitive errors, and avoidance behavior. And as we'll see, those three, minimal number of elements really come together in a self-reinforcing cycle of behavior, which becomes tremendously problematic. And there are several different types of anxiety disorders. You know what they are: generalized anxiety, social anxiety disorder, panic. OCD and PTSD have been removed from the anxiety disorder classification in the DSM. For our purposes, all of those disorders are subsumed under the general term anxiety disorder because structurally they are all similar. They might have unique presentations of behaviors and cognitions, et cetera, that show up, but they're all more alike than they are different, as Heuristic Sullivan might have said. This diagram shows the process of self-regulation. This is within all of us at any given moment in time. We're all experiencing a situation which is serving as a cue. It's guiding where we focus our attention, which determines what we wind up perceiving. That leads to thoughts and emotions which arise and maintain and inform one another, eventually leading to an interpretation, which then leads to an action urge or a behavioral urge, finally ending up in an action sequence or a behavior. When problematic anxiety is the emotion that's predominating this self-regulation landscape, what tends to happen is feeding forward and driving of avoidance or safety behavior. And this is problematic because the avoidance and safety behaviors feed back and wind up distorting the whole self-regulation landscape. Winds up turning that cue into an urge for future behavior, winds up taking the interpretation in a distorted direction, winds up guiding cognitive errors instead of a clear-minded thinking process. Attention turns into hypervigilance, and so on and so forth. All of these components wind up leading to more avoidance and safety behavior, which is the main target of any treatment for anxiety disorders, because avoidance and safety behaviors are central to the way that fear is learned. And they're also central to the way that fear can be therapeutically unlearned. So fear conditioning is the process by which emotional experience of fear gets encoded and learned as a response for future instances of running into the same cue. Fear conditioning goes something like this. A person is at emotional baseline and all of a sudden there's a cue or a prompting event. This leads to an increase, in this case specifically, of the emotion anxiety. That increase in anxiety, as we saw, is going to drive a behavior urge to avoid or escape some safety behavior, which is going to bring down the anxiety very quickly. And that's the thing about safety behaviors. They work, right? They work to bring down the anxiety. That being said, exposed to the same cue, the next time, because the safety behavior occurred, the anxiety is going to be more intense. It's going to last longer. But when the person does the safety behavior, it's going to work just as well. And they're back to baseline, hence creating the illusion that the safety behavior is actually a good move, and so on and so forth. Extinction learning is the opposite process of the fear conditioning. This is the process that we try to mobilize during therapy for anxiety disorders. Instead of the safety behavior, we now have response prevention. Response prevention is just that. The usual behavior that happens, the safety behavior no longer happens. So the reinforcing quality of the safety behavior is blocked. But subjectively at the moment, anxiety increases when there's response prevention. That being said, there's no emotional response that lasts forever. And eventually it drops back down and hits baseline. Now, re-exposure to the same cue prompts less anxiety. And if there's still response prevention, it might rise, but then it returns to baseline. And the next time the cue is experienced, so on and so forth, until eventually extinction learning has occurred and the cue no longer prompts the anxious response. This is the goal of all treatment for anxiety disorders, whether it be psychological treatment or pharmacological treatment. One of the points that I really want to emphasize here today is that pharmacology for anxiety disorders needs to be working in the service of these behavioral goals, these psychotherapeutic goals. If it's not doing that, then it's just symptomatic treatment and it's not really leading to an outcome that could be called successful, as we'll see when we talk about the remission and the recurrence rates of anxiety disorders. And so extinction learning as a therapeutic maneuver maps onto that very end, the behavioral end of that process of self-regulation that we were discussing. And its outcome is a normative emotion state that's no longer compatible with an anxiety disorder. So there's no reinforcing cycle of emotion leading to more behavior. So we discussed anxiety disorders. What are you guys seeing right now? Are you still seeing the slideshow? Because my screen changed on me.
Yes,
okay.
We're still seeing this.
But it looks like we're good. Sorry, something just popped up on my screen. All right. So we talked about anxiety disorders generally in terms of their psychopathology and their origins in that fear conditioning process. Now let's talk about what severe anxiety disorders are. They're defined by greater frequency and intensity of the core symptoms, subjective anxiety, behavioral urges to avoid and whatnot, leading to more behavioral avoidance because the severity of the driving forces is higher, which leads to more functional impairment. And characteristically, they tend to present as multiple concurrent anxiety disorders of varying severity, but the overall severity is high. and they predispose to depression. And already major depression and anxiety disorders are highly comorbid, so much so that there's speculation about a common neurobiological pathway leading to both. But when the anxiety disorder is severe, more so even than less severe concomitantly occurring anxiety disorders, tends to be comorbid with depressive illness. Most importantly, the level of impairment with these severe anxiety disorders is profound. Productivity and quality of life impact comparable to schizophrenia. And treatment-resistant anxiety is another construct, even beyond the complex anxiety, the severe anxiety disorder. Some anxiety disorders just don't respond to available treatment. And still, there's no established definition of what treatment resistance in anxiety disorders means. For the most part, it's conceptualized as failure of two first-line treatment modalities. So that would be cognitive behavior therapy or an SSRI, either concurrently delivered or consecutively delivered. There's very little research on treatment-resistant anxiety disorders. The guidance available is very limited, and most of it is extrapolated from non-treatment-resistant anxiety studies. And some factors have been identified in this non-response of anxiety. And the pathology itself, we just don't know enough about anxiety disorders. They're very complex, and they cut across multiple neurotransmitter systems, et cetera, et cetera. There are environmental stressors that are contributing to non-response. And patient factors might include comorbidities or non-adherence to treatment. And finally, clinician factors, lack of expertise in delivering the treatment or the availability of providers. Unfortunately, that treatment mode, which we all take for granted in this part of the world, in our neck of the woods, cognitive behavior therapy, it's not that available out there. And when it is, it's usually cognitive behavior informed therapy as opposed to a strategic, well-implemented plan of psychotherapy, which is what CBT is meant to be. So, it's fantastic that we actually have really effective treatment. One way to look at it, the response rate to readily available treatments like CBT and SSRIs is 40 to 90%. Unfortunately, another way to look at it is that up to 60% of cases fail to respond to first-line treatments. And regardless, when we're looking at response status, the numbers might look good depending on how you look at them. But when we look at actual remission, no impairing symptoms, no quality of life limitations, the actual outcomes are less encouraging. And even those who hit remission, the recurrence rates are truly astronomical. And astronomical, he really must be exaggerating here. Not so much. We're in a population study. This is a non-clinical sample looking at, I think it was about 500 people who had had a lifetime anxiety disorder that moved to full remission. The study then looked at how many of those people had a recurrence of anxiety, and the numbers, they're not terribly encouraging. Prompting the study authors to conclude that recurrence of anxiety disorders is common and it extends over a bunch of time, such that even years after hitting remission, people might still be at risk of recurrence. And yet, even with its limitations, we actually do have effective treatments. There's limited guidance, though, on what treatments to use beyond those first few intervention steps. Most any clinician, whether prescriber or not, can tell you that you're going to start with an SSRI or CBT. You're going to add the other one, but then what? The data is really limited on what treatments are particularly effective in severe treatment-resistant cases. And there's very little focus in any of the treatment studies available on improvement that really hits that point of remission that goes beyond just treatment response. quality treatment for anxiety disorders looks like psychotherapy first and foremost, because again, the main object of treating an anxiety disorder is getting that behavior pattern of avoidance or safety behaviors to change. The CBT is the main mode of treatment for anxiety disorders. Its primary goal is to stop that disordered behavior using the behavioral track of CBT, so exposure with response prevention, or ERP. For PTSD specifically, a variant of the behavioral component of CBT is prolonged exposure. And in both of them, cognitive restructuring is the way to target the cognitive aspects of the disorder. First-line medications are SSRIs or SNRIs, specifically venlafaxine, has been studied and recommended as a first-line agent. Medication-wise, second-line agents are tricyclic antidepressants, TCAs, benzodiazepines, and the GABAergic antiepileptics, GABA being the main inhibitory neurotransmitter system in the brain. Certain of the antiepileptic drugs are predominantly effective on the GABA system, and those are good second-line agents, excuse me, per the treatment algorithms. And again, per algorithms, the usual treatment strategy is you start with CBT or SSRI, take your pick. And if there's a partial or no response to that first choice, you add the second one. So you start with CBT, partial response, add an SSRI. Step two, 2A is partial response, change the medication to another SSRI or an SNRI. If you're dealing with OCD, maybe you'll consider clomipramine in that second step. Or if there is a partial or no response, you could optimize CBT delivery, right? You could do more frequent exposure and response prevention, or you could tailor the treatment so that it has more of a cognitive restructuring component. And then there's step three, where we're pretty much on our own. Not quite exactly, not yet. In a partial medication response, we seek to augment the treatment. So there's some response, which means we don't want to scrap the initial approach. So let's add something that's going to boost that approach's effectiveness. If there is no medication response, then switch it to a different class or to a higher potency agent. A different class might be going from an SSRI to an SNRI. A higher potency agent might be going from, say, Zoloft or sertraline, which is a highly selective serotonin reuptake inhibitor, to fluoxetine, brand name Prozac, which is in pharmacological parlance a dirty drug. It hits other receptors. Yes, it hits the serotonin receptor, but it has some impact on norepinephrine receptors and on dopamine receptors, and that dirty drug quality sometimes makes it a more efficacious treatment. Likewise, venlafaxine, SNRI, and the tricyclic clomipramine are often used for that higher potency effect in this stage of treatment. And finally, step four, now you're really on your own. There's just not a lot out there in terms of where do you go from here. So now I'd like to present a heuristic approach to treating severe, complex, treatment-resistant anxiety problems. When I say heuristic, I mean an approach that is pragmatic, practical, and not in any way guaranteed to be optimal, perfect, or rational, but it might be enough to get us where we need to be at the moment. First and foremost, when you're up against an anxiety disorder that isn't responding the way that you want it to, you have to be sure that you're dealing with an anxiety disorder, because good treatment extends directly from good assessment. And so first and foremost, you're going to rule out conditions that might mimic anxiety. That could be a biological condition such as hyperthyroidism. And let me just take a moment to say that it's much more common for a medical condition to mimic an anxiety disorder. In other words, for anxiety to present as a medical symptom than it is for a medical condition to present as anxiety. Yes, it could happen. It certainly is possible, but there's not going to be as high a frequency of that happening. Hyperthyroidism is fairly common and can present with anxiety symptoms. There's another condition called pheochromocytoma, which is a tumor condition of the adrenal glands that sit atop the kidneys. Pheochromocytoma leads to an extreme paroxysmal, sudden, intense burst of what's called cold fear. And so there's the physiological fight or flight response that we see in fear and anxiety disorders, but subjectively, the person doesn't feel tremendously anxious. They can kind of coolly observe the fact that their heart's beating at 160 beats per minute, and they're sweating profusely and having a hard time catching their breath. This is because the tumors are compressing the adrenal gland and causing this massive efflux of noradrenaline into the bloodstream. So the person is in full-on fight or flight physiologically, but not cognitively and emotionally. If you ever see that in clinical practice, email me and let me know you caught it. You'll be a superhero. That's super rare, and it's so unlikely to present as a psychiatric or a psychological concern, because it's so florid, the person's going to probably be picked up by a medical doctor first. Hyperthyroidism, keep an eye out for it. Bipolar 2 disorder, this is one of those conditions where the elevated mood state might not really show up as hypomanic, at least initially. Initially, when bipolar type 2 is first establishing, the person might be irritable and extremely anxious as their first presentation. And this could look a whole heck of a lot like an anxiety disorder with maybe a major depressive disorder co-occurring. This is problematic in terms of treatment, because if you treat a bipolar 2 disorder with the usual pharmacologic treatment, SSRI, thinking that it's an anxiety disorder with a comorbid depression, you're going to exacerbate the picture. So in this first step of our heuristic here, taking a strong family history and trying to get a sense of anybody in the family with mood swings, with real big up or downs, impulsive spending, the whole gamut of go, 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 do, driven, hypomanic behavior. It really pays to spend some time there and to exclude this from the possible diagnoses, because treatment as usual could actually be a compromising factor if the person has a bipolar 2 presentation. Substance use disorders, both in terms of intoxication, cocaine, amphetamines, and in terms of withdrawal, opiates, benzodiazepines, present with profound anxiety symptoms as part of their diathesis. And so it makes sense to dive in and see, does this person have a substance use disorder that I'm missing? And before you come to the conclusion that this is a treatment-resistant anxiety disorder that I have to go after with guns blazing. Finally, ADHD. ADHD, if you recall our schematic of self-regulation, see that along the chain of self-regulation, really early on, after the cue and after that initial perceptual input, there is attention, where we place our attention, attentional regulation, attentional deployment and stability. All of that influences how we experience and therefore wind up responding to cues in terms of the thoughts that we have, the emotions that we feel, what urges we have, what we feel like doing behaviorally, and eventually what our behavioral output is. So anxiety symptoms are actually very common in ADHD, both because subjectively the person has the experience in their life of ineffectualness. I often forget things. I often miss stuff. I often space out and don't pay attention, and therefore blank, blank, blank. You know, they've also been told a bunch of times by parents, siblings, teachers, anybody who has to deal with that, that, you know, there's something wrong with you. It's one of the tragic pieces of ADHD, such a highly treatable condition, is that if it's not identified, people actually wind up incorporating these really ineffectual schemas about themselves. So if ADHD is part of the picture, it makes sense in treating it. Likewise, with any of the other conditions, as part of our step 1 heuristic here, if there is a comorbidity that you identify, even if you have a mistake in the anxiety disorder for something else, if there's something comorbid, treat it. That treatment of the comorbid condition might be the catalyst necessary for the anxiety treatment to proceed as desired. Step 2 in our heuristic, assess for factors that could worsen anxiety symptoms. Sleep deprivation, known to worsen anxiety states, even in people that don't have anxiety disorders. Difficulty with processing information, making decisions, therefore leading to that subjective sense of anxiety. Social and environmental stressors, of course, if somebody is struggling to make enough money to keep a roof over their head, there's this existential threat to their well-being. An anxiety disorder might still be a problematic and maladaptive way of behaving, but in terms of the subjective emotion state of anxiety, it makes sense there. And so that environmental stressor needs to be targeted and remediated to the degree possible if treatment is to proceed. Caffeine intake, it's so often overlooked. Anecdotally, I had a client one time that I was treating for a different condition, an eating disorder, but very significant anxiety presentation that was just not budging, despite the fact that we had identified it as a driving factor in the eating disorder from which the person was highly motivated to recover. Turns out that this person was consuming 3 or 4, what's the largest size of Starbucks coffee? I forget the name of it, the huge one, the venti, with 3 additional shots of espresso 3 times a day. And when we got her to cut down on that, the anxiety symptoms cleared up. But when she cut down on that, we discovered that she had horrible ADHD, which she was self-medicating with caffeine, treated that, and then the anxiety picture really cleared up and she achieved full remission from the eating disorder. And this is an example of how kind of conscientious targeting of symptom domains is the way to improve treatment regardless of what it is that you're treating. And that's what we're trying to do here with this heuristic approach. Next, are we sure that the treatment to date has been correctly delivered? Has the SSRI been dosed appropriately? For panic disorder, the dosing for SSRIs is beneath what we would use for major depressive disorders. But for OCD, the dose of SSRIs needs to be at the higher end of normal or beyond. So take, for example, sertraline, Zoloft. For major depression, the upper limit of approved dosing is 200 milligrams a day. For OCD, the approved upper limit is 300 milligrams a day. In clinical practice, I have some patients with OCD taking 450 milligrams of sertraline a day because they needed more. There was a partial response, and because I know that sometimes more is more when it comes to SSRIs and OCD, I just pushed the dose and eventually was able to hit a full treatment response without adding anything, without changing the medication. So is the treatment being correctly delivered on the pharmaceutical end? But this also applies on the psychotherapeutic end. Is a person seeing a CBT specialist who's running through a protocol of CBT and really working on the behavioral components of the disorder with exposure and response prevention? Or are they seeing somebody who's doing CBT-informed psychotherapy, teaching relaxation exercises, stress management, and doing some cognitive restructuring, but not focusing on the behavioral output and not using exposure with response prevention? And it's extremely common with CBT for providers to have working knowledge of it, to claim it as an area of expertise, but to never have done any exposure work whatsoever, because exposure is really hard. It's hard to implement as a clinician. It's hard to go through as a client. And that some clinicians avoid it, thinking, "Oh, why would I cause my client more distress by putting them in a situation that exacerbates their anxiety?" Which is why I hope that clinicians watching this presentation walk away with a real understanding of that fear conditioning and extinction learning, which predicates the need to target behaviors as the sine qua non of effective anxiety disorder treatment. And by the way, I show that model to my patients all the time. Typically, I just throw it up on a whiteboard with markers. Now that I've made some slides showing it, I could save myself that step. But patients really resonate with that. When they see the fear conditioning process, they're like, "Oh yeah, that was me." Yeah, every time I avoid, it seems to get worse. And when you show them that extinction learning is going to worsen their anxiety in the moment, but it's not going to stay that way forever, and eventually they could roll back the anxiety process, the majority of people are like, "When do we start?" Because they want something that works, even if it makes them uncomfortable in the moment. So our treatment being correctly delivered in terms of dose, in terms of timing. Let's talk about timing in SSRI. So we talked about the dose sometimes needing to be lower or higher depending on the condition. In major depression, we know that SSRIs are going to take some time to work. 2 through 6 weeks or so is what's expectable, maybe 8 weeks. In anxiety disorders, sometimes 6 weeks is the minimum that we might have to wait. And as far out as 12 to 24 weeks, there could still be accumulating benefit at any given dose. That's not something that's in common knowledge, at least wasn't when I was training, and I haven't heard it in common knowledge about SSRI management of anxiety disorders. So that very often leads to treatment switches before the time frame when we could expect the treatment to start becoming effective. Moreover, studies that have looked at more mid and long-term outcomes with regards to medication management for anxiety disorders show that in the second 6 months of treatment with the same agent, there might be even further gains than in the first 6 months. So it's not just wait 24 weeks. It's, could this medication, could the person convert to responder status if we give this enough time? That's an important question, because otherwise you're hopping from medication to medication and stopping all of them before that moment of potential response comes into the picture. Now, it's hard. It's hard when a client has severe anxiety to tell them, let's wait 12 weeks before we do anything here. Now, that might need to be addressed symptomatically. That's a rational use of benzodiazepines to bring down anxiety and keep therapeutic optimism high so that the person can hang in there until the SSRI's therapeutic response kicks in. But certainly bearing in mind that the timing of the treatment intervention needs to be taken into account is an important step in optimizing treatment. And finally is the treatment being adhered to by the client. If you're looking for the number one cause of treatment non-response, it's usually client adherence to the treatment. Multiple missed doses in a week of SSRIs could start to dilute their effectiveness. And if the patient is not doing their CBT homework, the treatment is not going to work. So step one of our heuristic, to recap, we made sure it was an anxiety disorder and not something else. If something else was in the picture, we treated it. We made sure to correct any lifestyle, behavioral, environmental factors to the degree possible that are contributing to the anxiety disorders and transigens. And we made sure that the treatments that are offered are being delivered appropriately and used appropriately. So let's assume that we've gotten this all squared away. What next? Next, we go back to our model of self-regulation, because that same model of moment-to-moment normative self-regulation actually is a good place to hang all of the symptom domains that we see in anxiety disorders. The bottom line is, if we look at this process diagram, we could see how all of the major symptoms of anxiety map onto it. So in terms of the situation and cue, there could be a hypervigilance, a predetermined worrying about the possible emergence of that cue. Again, well, if this happens, what then? In terms of perception and attention, those could get hijacked in terms of a selective attention towards the threat, biased attention towards threat, and interoceptive focus, especially in panic disorder, body-based cues. The cognitive and interpretation part of self-regulation, that's where obsessions and ruminative thinking and cognitive errors hang their hats. In terms of emotional experience, there could be broad-based emotional dysregulation or broad-based emotional suppression as a result of the extreme anxiety state. The urge component of self-regulation is waylaid by avoidance urges, compulsive urges, and all of it leads to the avoidance, compulsion, or safety behaviors that keep the anxiety disorder going. So let's look at the perception and attention piece of self-regulation. If we were to have a patient struggling with anxiety disorder treatment, we know that they are taking the medication, they're doing the homework, they're doing in-session exposure with us, but during the in-session exposure, we notice that we ask them to keep firmly in their mind the awareness of the cue that they were just exposed to and their anxiety state and how it's moving. Is it dropping? Is it rising? What's going on right now? And we see that the person consistently has difficulty identifying where their emotion is. I don't know, I guess maybe if we're no, a 6. You start to wonder, is this person able to maintain continuous attention on their subjective state right now? Because we need the information on that subjective state, but moreover, they need to experience it. Part of the extinction learning is I notice anxiety rising after I was exposed to the cue, and then I notice it starting to stabilize. So it's not gonna rise forever. Oh, and look, now I notice it falling. Oh, wow, look at that, I'm back to baseline. That continuity of experience from elevating anxiety, stabilizing, dropping back to baseline, that's what's new learning in extinction learning. And if the person isn't able to maintain attentional stability enough to take all of that in, all of those moving pieces, that continuum from extreme anxiety back down to baseline, extinction learning might not take hold and the person's anxiety levels won't change. So this is where, and to boot, I'll add, and remember, I'm doing this without presenter notes, so I'm just kind of making stuff up based on what I wrote earlier. Hopefully I'm hitting the main points, but I just remembered something that I had written about how much attentional processes can influence anxiety and vice versa, right? So attentional dysregulation, even in non-clinical anxiety disorders, and a person with ADHD often leads to the experience of anxiety. And likewise, anxiety winds up disrupting attentional processes. But to the degree that the attentional process is feeding on down the line and keeping the anxiety disorder immobile, we might treat those directly. We might use an alpha-2 agonist, such as clonidine or guanfacine. Both of those are indicated in their extended release forms for ADHD. But they both downregulate the sympathetic nervous system, therefore attenuating the fight or flight response. And in so doing, they could disrupt anxiety's impact on attentional stability. One thing that I've seen clinically, and I don't have research data to back this up, so take this with a grain of salt, but patients that I've treated for hyperactive impulsive ADHD with an alpha-2 agonist, almost every case of ADHD has some combination of all of the core features. So a person might present with hyperactive and impulsive as their primary ADHD flavor, if you will, but there is still some inattentiveness and difficulty with deploying and sustaining attention. I have found consistently that people report, yes, I'm less hyperactive, I'm less impulsive, but they report an improvement in their ability to deploy and sustain attention that wasn't part of the treatment target initially. It has become so since I've started to realize that this effect in multiple series of patients holds true. But yeah, that might be a play here as well. If you optimize if you optimize attentional stability, then you're going to improve anxiety disorder treatment outcomes. With regards to that interoceptive focus and panic disorder, and sometimes also in generalized anxiety disorder with strong health concerns or emetophobia, there's this real attentional gravity towards somatic sensations. The anticonvulsant pregabalin, or Lyrica brand name, has shown to be particularly effective in reducing this interoceptive awareness and therefore not having that feed forward into the anxiety process. When the self-regulation failure that we identify as contributing to the anxiety disorders treatment difficulty is in the cognitive and interpretation part of self-regulation, we often see an extreme obsessionality, persistent and intrusive ruminative thinking, and cognitive errors, catastrophizing, for example, that are prominent and seem to be the operant factor in the disorder not progressing. So we might target treatment there. This is where atypical antipsychotics can be useful. Obviously, a medication choice that's way down in our treatment algorithm, but here we're at step 4 and beyond. This is where we're on our own. There isn't a lot of information out there, but there is information substantiating the use of atypicals, especially in OCD, but in all of the anxiety disorders, atypical antipsychotics have been tested, and in all of them, they've shown some degree of effectiveness. Interestingly, the effectiveness that they show in all of the anxiety disorders seems to be predicated on the ability to decrease the intrusiveness of cognitive experience. And so in OCD, that shows up as less frequency and intensity of obsessions, and GAD as less ruminative in. But if you stop and think about how these medications work in psychotic illness, and if you've ever had the experience of seeing somebody go into a psychotic state and or come out of a psychotic state, it's really clear that a big part of the pathology at the higher levels of severity is the intrusiveness of the person's cognitive experience. Yes, there's a distorted sense of reality. There's a deficit in reality testing. But even with that deficit in reality testing, if the person's cognitive experience, the thoughts about that reality, the paranoid ideation, isn't intrusive, then subjectively the state is less severe. And I think that all of these dopamine active antipsychotic medications might serve as a common pathway to decrease the intrusiveness of cognitive experiencing and therefore lead to improvement in whatever condition that cognitive experiencing is a part of, including anxiety disorders. Let's say that emotion dysregulation, the emotion self-regulation domain is where we're seeing a stuck point in anxiety treatment. This might present as the person with anxiety who is undergoing exposure and response prevention. And every time that the most low order exposure, you do the hierarchy, the thing that should be the easiest for them to target and manage all the way down to extinction, it consistently leads to a 10 out of 10 anxiety, and it only drops to a 7 out of 10 no matter how long you continue with the exposure exercise. This person might be up against this vulnerability to dysregulated emotion, as Linehan puts it in DBT, that intense vulnerability to emotion sensitivity, small cues setting off big responses, reactivity, the responses being large in magnitude and quick to rise with a very slow return to baseline. Some people are wired high for emotion, and this is their experience. And that experience is dramatically different from the experience of somebody for whom it takes a relatively large cue, and that leads to a relatively slow and modest emotional rise, which pretty quickly returns to baseline. This is neurobiological wiring, but the subjective experience is night and day from one to the other. If a person is really vulnerable to emotion, or conversely, if they're consistently suppressing emotion, exposures, no, I have no anxiety now. This happened, I only have anxiety when I do this at home. I don't have anxiety when I do this here. I mean, naturally, you might want to rework your exposure exercise there, but those two, emotional dysregulation and emotional suppression, are both two sides of the same coin, if you will. Both of them are speaking to the same phenomenon. This vulnerability to emotion that might be excessive for the demands being placed on the person at the moment. Here, the anticonvulsant mood stabilizers might be particularly helpful, and especially lamotrigine. In my clinical experience, let me just back up a second. As a psychiatrist that's also intensively trained in DBT, I very often see clients for pharmacotherapy in the service of a DBT treatment plan run by another clinician. It's always useful to have your prescriber know what the heck you're doing in therapy. So those are the referrals that I get very often. And I have a lot of experience in using lamotrigine as a pharmacologic intervention for this baseline biologically wired emotional vulnerability. And I can tell you from my clinical experience, and there are some studies out there that are contradictory, but some certainly do bear out that lamotrigine seems to have kind of a selective responsiveness in terms of emotional vulnerability without affecting the overall mood picture very much. And what I'm trying to say with this is that even if there isn't a mood disorder component to a person's clinical presentation, if one of the components is extreme emotional sensitivity and reactivity and a hard time getting back to baseline, targeting that with medication management, with a medication such as lamotrigine, which is fairly low impact, very tolerable medication, invisible, works in the background for the most part, it can make a big difference, because from a dialed down level of emotional reactivity, a patient's behavioral repertoire really opens up. So in conclusion, anxiety disorders are common and very commonly impairing, more than we even realize, I'm certain. Their treatment is, for the most part, straightforward, and we do have treatments that work, but sometimes they don't, and sometimes the treatment process is very complicated, and when it is complicated, there's very little guidance on what you could do to improve the treatment outcome. But if we take our knowledge of how anxiety disorders present and evolve, and if we guide our choices then on some heuristic way of approximating the response that we're looking for, we're much more likely to make a good treatment choice rather than just at random picking of available alternatives. And finally, this same heuristic can be equally applied to optimizing CBT delivery, because the medication management is one piece of the treatment. Arguably, the more important piece is CBT, and it's not always hitting the appropriate target. And so, excuse me, for example, a patient where the cognitive and interpretation piece is particularly problematic, a lot of rumination, a lot of catastrophic thinking, there may be a need to modify CBT, moving away from the exposure and response prevention work and doing more cognitive restructuring until that part, that domain of the anxiety disorder is better managed. And then you could start focusing on better behavioral outcomes. So thanks for your attention. Sorry about the audio video glitches, and I'm looking forward to the questions.
Thank you so much, Dr. Canosa.